start. Welcome everybody to this Waterloo research seminar, and I welcome you all today here to listen to Dr. Marina Mourtzakis. Before we start, I have one announcement, and that is we have a special seminar next week, next Wednesday, which is November 26th, and it will be in room 1302, which is just around the corner. Our guest speaker will be Stephen Walker. He is coming from the United Kingdom. He's a professor of healthcare at the University of Manchester. He is the IS Program Director of the National Institute for Health Research, as well as the UK Clinical Research Network, and Chief Information Officer of the UK Biobank. So I don't know how he does all of these jobs at the same time, but he is coming to speak to us about healthcare, biobank, and research information systems in the UK. So this would be an opportunity to find out what is going on in the United Kingdom, where they're moving to in terms of their healthcare organization and information systems, as well as this very innovative UK biobank. So please join us next week at 3 o'clock, and that's Wednesday, November 26th in DC 1302. Now I'd like to introduce to you our guest speaker for today, who is Marina Mourtzakis. Marina comes to us from, were you most recently at the University of Alberta in Edmonton? She received her BSc and BChem from McMaster University and a PhD from the University of Guelph. She is an assistant professor in the Department of Kinesiology at the University of Waterloo. Her current program integrates research in nutrition, muscle metabolism, and body composition. It translates concepts of nutrition and exercise required for optimal muscle function in healthy humans towards understanding and mitigating muscle atrophy in cancer patients. Her research interests focus on understanding this phenomenon and identifying nutrition and exercise interventions that counter these detrimental changes. Today, she'll be talking on integrating medical imaging and health records to understanding detrimental changes in metabolism and body composition in cancer patients. So please welcome Marina.
Thank you for the introduction, and I'm actually a fairly new faculty here at the University of Waterloo, so it's exciting to be here and exciting to have this opportunity to share some of this work with you. I'll start off by giving you a little bit of information about my, about my background. I started off with a keen interest in human health and studied kinesiology and biology. Having a little bit of a problem here. There we go. I started off with my undergraduate studies, as Shirley alluded to, in biology, biochemistry, and kinesiology. And during this time, I developed a keen interest in furthering this work in graduate studies at the University of Guelph under the supervision of Dr. Terry Graham. And I studied muscle physiology, nutrition, and metabolism at the University of Guelph. Particularly, I was interested in understanding how protein nutrition plays a role in energy metabolism in muscle. I developed a keen interest in applying these concepts to unhealthy populations, to clinical populations. In particular, I was interested in learning more about muscle wasting in cancer patients. So I went off to the University of Alberta to do my postdoctoral work with doctors Vicky Barricos, Tony Ryman, and Linda McCarger. And here I learned a lot more about body composition and the changes in body composition that occur in cancer patients through the disease trajectory. So in all of this training, I've integrated a number of these concepts, and I continue to embrace the idea of taking work from the bench to the bedside and back again, and you'll see that in some of the work that I'll be embarking on here in the Department of Kinesiology. So, why study metabolism and body composition in cancer? Specifically, when we have more than 63,000 new cancer diagnoses in Ontario this year, the majority of our research focus is on anti-neoplastic therapy and countering tumor growth. However, what's underappreciated is that the vast majority of these cancer patients undergo detrimental changes in body composition, including gains in fat mass, loss of fat mass, and in particular, my interest is in loss of muscle mass. We know that there's specific profiles and specific changes in body composition that relate to poor treatment and survival outcomes, and this has only come about in the last few years. Now, many of you are familiar with the diversity of body composition that exists in healthy populations. We have those who are agonizing over gaining every last protein and making that into muscle. We have the other group of individuals who voluntarily try and lose weight with the latest fad diet. My particular interests in diversity of body composition encompass involuntary weight gain and involuntary weight loss that occurs with clinical populations. There are specific implications of these body composition changes that occur. Total adipose tissue, for example, a gain in total adipose tissue, is related to atherogenic blood profiles, insulin resistance, as well as risk of cardiovascular disease, diabetes, and cancer. Specifically, visceral adipose tissue, which is the fat that encompasses around the internal organs, is also specifically related to metabolic syndrome, cardiovascular disease, and insulin resistance. On the other hand, we have muscle loss, and that can occur either in conjunction with gains in fat or in conjunction with loss of fat. What we see in these particular patients is that loss of muscle is related to risk of falls and fractures, and we see this particularly in elderly populations. In the general in elderly as well as clinical populations who have lost muscle, we tend to see functional disabilities that prevail. And a greater concern, immune dysfunction, infections and complications that arise, and the increased rates of hospitalization. And inevitably, in some patients, we also see increases in rates of mortality in individuals who have accelerated loss of muscle. Now, these body composition changes we've seen in so many different weight-related diseases or disorders. For example, prevalence of obesity is smacking us dead in the face these days, and this is related to diabetes, where we also see gains in fat and losses of muscle in these particular clinical populations. There are a whole realm of other disorders that we see where we see muscle wasting develop. And my particular area is looking at cancer and understanding the implications of body composition in cancer. It's a complicated area to evaluate. And one of these reasons why it's been a complicated area to evaluate is that there are dynamic changes in body composition that occurred throughout the disease trajectory. For example, incidence of breast, prostate, colorectal cancer, and GI cancers are normally related to obesity. On the other hand, patients such as breast and prostate cancer patients who are undergoing different types of chemotherapy or radiation therapy tend to develop fat gain and muscle loss. For individuals who exhibit disease progression, we tend to see an accelerated muscle loss in these particular patients and accelerated fat losses as well. So as you can see, I've simply categorized the changes in body composition in 3 different groups. But even within these groups, we have dynamic changes that occur, and it makes it very difficult to understand what is going on in these patients and how we can actually intervene. Specifically, changes in fat and muscle have specific implications in cancer. The amount of muscle and the amount of fat an individual carries can have adverse reactions or have different responses to treatment. For example, the lower the amount of muscle an individual has can relate to treatment toxicity or poor responses to treatment. Accelerated losses of muscle are also related to reduced survival. We've also seen in breast and prostate cancer patients who I earlier said gain fat and lose muscle, they tend to develop disease recurrence and other morbidities during their survivorship period. So despite the fact that we have a lot of growing successful interventions for antineoplastic therapy, we're now developing other diseases and other problems in these particular patients. So my research aims have been to evaluate the changes in body composition that occurred during the disease trajectory and understand the time course that these changes develop in. This will allow us to relate these body composition changes to metabolic outcomes, nutrition, as well as various the lack or increased activity in these patients. This will then allow us to ultimately develop nutritional and activity interventions that counter these particular deleterious changes in body composition. So, pertaining to the title of my talk, where we can integrate health records and medical imaging, this has played a huge role in the recent years in evaluating body composition. Particularly, we've developed various methods of quantification of body composition that are much more precise and specific, and have related these changes in body composition to various clinical outcomes, and now are trying to identify the changes that occur in the time course of the disease trajectory. I'll start off by talking a little bit about the methods that we've developed to measure precisely the changes in body composition. We know that about 40 to 80% of advanced cancer patients will exhibit involuntary weight loss of more than 5% of their body weight within that first month of diagnosis. We've known that actually for about 20 years. What we don't realize and we're starting to recognize is that weight loss or weight gain actually represents the net change in all tissues. And what I mean by that is that we're assuming that a loss of a certain amount of weight is equated to a loss of all tissues, a loss that we see in all tissues, and that all tissues experience the same magnitude and direction of change during a disease trajectory. Now, this has implications for different interventions that we use. For example, if we're using protein nutrition to try and counter muscle loss, we have no idea whether we're actually successfully maintaining muscle mass in these patients. Bioelectrical impedance is a methodology that has been used. It's a clinically expedient tool for measuring lean and fat tissues. Problem with bioelectrical impedance is it comes with some imprecision. And although there is evidence that loss of lean tissue using bioelectrical impedance is related to reduced survival in cancer patients, we have recently seen that bioelectrical impedance can actually over or underestimate lean tissue mass in patients. And this can occur up to about 9 kilograms of fat-free mass. So it's really not telling us a lot of information, precise information about what is occurring in these cancer patients. And this might actually underestimate the prevalence of muscle wasting or fat wasting in patients with cancer. Now, muscle is an important tissue for energy balance, for immune function, and for insulin metabolism. To date, most studies have used lean tissue as a surrogate measure of muscle mass. Now, unfortunately, this comes with a few disadvantages, as body composition, as I mentioned earlier, is unique in cancer patients. More specifically, lean tissue involves skeletal muscle, liver, spleen, and various other internal organs, which can hypertrophy or atrophy at various points of the disease. Fluid status is altered in cancer patients. In some cases, you have patients who are incredibly dehydrated. In advanced cancer patients, you have patients who develop ascites, and therefore their fluid status is elevated. Tumor involvement. Tumor is actually seen as lean tissue when you use modalities such as bioelectrical impedance. So the lean trunk mass, okay, all of these organs are generally located in the trunk. So lean trunk mass comprises of organs that dynamically change throughout the disease trajectory. And this confounds our measures of whole body lean tissue mass. So there are a couple of modalities that we have been using that are particularly precise and allow us to do some really interesting measures in body composition in cancer. One such modality is dual energy X-ray absorptiometry. For those of you who might not have heard of dual energy X-ray absorptiometry, which I'll refer to as DEXA from now on because it's a mouthful, many of you might have heard of bone densitometry, and it's the same modality. DEXA actually was originally used for bone mineral density calculations or measurements, and evolved to include body composition measurements that involved fat and lean tissue changes in patients or subjects. So what's great about using DEXA is that it's highly precise. We can actually get measurements that are less than 2% coefficient of variation. That's incredible. It's low dose radiation. So we can use this multiple times through a trajectory and track changes in body composition that occur in patients. And the other fantastic thing about DEXA is that we can compartmentalize our measurements. So for example, I could specifically measure the amount of lean tissue that exists in, let's say, each arm. I could look at the left arm and the right arm individually. And I can do so with such precision that I could tell the dominant arm from the non-dominant arm. Now, compartmentalization is also great for cancer patients because, as I mentioned earlier, the trunk mass contains a number of different internal organs that show various dynamic changes throughout the disease trajectory. Well, with DEXA, we can excise the trunk tissue and simply look at changes in the limbs. And if we're looking at lean tissue in the limbs, we're essentially looking at skeletal muscle mass. However, we have limited access to DEXA in clinical settings. In fact, we have limited access to DEXA in general because we don't necessarily have one on campus either, but we're working on that. Now, one of the hidden treasures that we came across when I was out in Alberta is CT imaging. Why hasn't anyone thought of this earlier? We have an abundance of CT images that exist in the databases, in the health databases in hospitals and clinical centers. CT imaging is highly precise and is vastly accessible, particularly when you're working in cancer centers. And we have CT images that are performed routinely in cancer patients. Now, the methods that I'll be describing here can also be used when you have MRI images available to you. So what we can do with CT analysis is we can take a set of scans from a patient and download a specific region that we're interested in. We've been focusing in on the third lumbar vertebrae, and there's an established amount of literature that has looked at the third lumbar vertebrae. So it's a known area that we can compare to with healthy and other disease populations. The other great thing about using the third lumbar vertebrae is that it's a bony landmark. So it's consistent among the time course of changes in the disease. So we can follow a patient throughout the disease course and identify changes that occur in that individual across the disease time course. And one other bonus is that at the third lumbar vertebrae has actually been related to whole body distribution of corresponding tissues. So we know that if we measure lean tissue in the third lumbar vertebrae, we can relate that to whole body distribution as well. Now, in cancer, what we're able to do is download these particular images. So right now you're looking at an image that was downloaded at the third lumbar vertebrae, and it's a cross-sectional image. You have the third lumbar vertebrae here in white. In yellow, we have visceral adipose tissue, which is the fat depot that I talked about earlier surrounding all the internal organs. We have subcutaneous tissue in turquoise, which is the fat that lies just below your skin. And finally, we also have muscle in red, orange, blue, and purple. So we have all these pretty colors. And what we're able to do with our software is software can actually identify and distinguish between different types of tissues. So that's why we're enabled to actually distinguish between these different tissues. The other great aspect about this software is that we can actually quantify the amount of cross-sectional area for each tissue. Now, in addition to this, by having that bony landmark, we can then take a CT scan that was done in the same patient And in this case, we have 2 CT scans taken 6 months apart at the same bony landmark. And you can visually see the changes or the loss in fat and muscle tissue in this particular patient. We can also quantify the change and relate that to the time that's elapsed between the 2 CT scans. Now, another methodology that we've developed is to quantify muscle changes in the thoracic region. There's a number of cancer types, such as breast and lung cancer, who do not have abdominal CT scans taken. They only have thoracic scans taken, and we have been able to identify a technique so that we can quantify the changes in muscle in that particular region. So what has this shown us? Well, we have an extensive variation of fatness in advanced cancer patients. Most individuals view advanced cancer patients as being emaciated. What we found actually is that we have a huge variation, huge heterogeneity. In the, oops, wrong button. There we go. In the patient on the left, this individual has such a small amount of adipose tissue that it's almost like pinching the skin on the back of your hand. While on the other hand, we have an individual here who has a large amount of visceral adipose tissue, subcutaneous adipose tissue. And here we also have the green, which is intramuscular adipose tissue. In other words, fat has actually infiltrated in the muscle of this individual. On the other hand, we have extensive variation in muscularity in advanced cancer patients. Here we're looking at 2 different individuals who are the same height and weight. For those of you who are familiar with body mass index or BMI, they're the same BMI. However, when you take their CT images, you can see that the patient on the right is actually normal musculature for that person's age. The patient on the left is about 2 standard to 3 standard deviations below what is normal for their age. Now, this has important implications in a number of factors of cancer, survival being one and treatment being another that I'll talk about in the next few slides. One thing we did come across, though, is that independent of how much fat an individual has, 50% of patients that we had analyzed, at least, in particular, we looked at colorectal and lung cancer patients. 50% of them were sarcopenic, were below a normal musculature for their particular age. So I've presented to you 2 different modalities that I think are very precise and very handy in understanding body composition changes in cancer. One was DEXA, where we are able to have whole body imaging. Unfortunately, we can only get 3 specific compartments, whereas CT, we aren't able to get whole body imaging. The radiation is too high and it's too expensive. However, we are able to identify specific changes in various tissues throughout the disease trajectory. Now, we've developed regression equations that we can actually translate what we see in the CT images to whole body distribution. So, using these different methods, we have then been able to relate these changes in body composition to different clinical outcomes. One of the greater concerns that we have is, again, understanding the accelerated loss of muscle that we see in cancer patients, which is also known as sarcopenia. This has treatment interaction or implications as well as survival implications. Loss of muscle and gain in fat, also termed sarcopenic obesity, is also of great concern and has implications on treatment, functional status, as well as metabolic imbalances that may lead to risks of various other morbidities. Now, again, alluding back to my title, there is an enormous amount of information that we can extract from health records. And it's information that we can use in retrospective studies to build groundwork and build the basis for future interventional studies. These health records contain not only CT images, but CT scan dates, treatment plans, medical history, drug information, cancer type, and morphology. It's a wealth of information that we can access and relate to body composition. And again, this will facilitate the design of future prospective studies. One example of using health records to relate changes in body composition with clinical outcomes is a study that my group had carried out, and it was published in Lancet Oncology this year, where they used CT images, treatment, and diagnostic information to classify body composition of cancer patients. What they did is they looked at lung and colorectal cancer patients who had CT images available in a database, and they evaluated simply the obese individuals. So they extracted only the obese individuals and classified them according to obese individuals who had sarcopenia versus obese individuals who did not have sarcopenia, and related these classifications to survival and treatment outcomes. What they found was really quite intriguing. The patients with sarcopenia had a far reduced survival rate as compared to patients without sarcopenia, referring to the importance of muscle mass in these particular patients and the importance of body composition in survival. Now, there's also increasing evidence of sarcopenic obesity, as I mentioned earlier, in breast cancer patients. They tend to gain fat and lose muscle during the disease trajectory, and this might be due to the types of treatments that they're receiving. There's evidence to suggest that there are also metabolic perturbations that develop with these particular patients. In fact, there's some evidence to show that there's high levels of insulin that develop in patients who are undergoing certain types of chemotherapy. And this has been related to recurrence of disease as well as mortality. However, we have a very limited understanding as to the mechanisms that lead to these deleterious changes that we see in body composition. Now, we know from the literature that sarcopenic obesity is related to risk of cardiovascular disease, diabetes, as well as cancer recurrence. We have also started to see some evidence of atherogenic lipid profiles in these particular patients. We've seen disturbances in insulin metabolism in these particular patients and treatment complications that also arise. Similarly, we've also started to see changes or development of sarcopenic obesity in prostate cancer patients who receive androgen deprivation therapy. The problem here, again, is the development of other morbidities in these particular patients, such as osteoporosis, diabetes, and cardiovascular disease. And again, with the increasing success rates of various treatments in these particular groups, we're now dealing with other risks and other morbidities. In fact, recently, Tsai et al. Had published a paper in the Journal of the National Cancer Institute showing that prostate cancer patients who underwent androgen deprivation therapy and radical prostatectomy were at risk of cardiovascular mortalities. So, did they make the link between body composition? Well, they alluded to it, and that's where future work is certainly needed, is to actually make the link between the loss of muscle and increase in fat mass. And there are exercise studies that try to intervene and help maintain muscle mass in these particular patients. However, we don't know what the long-term effects are of these studies. What is particularly interesting as well is that this study was done purely using retrospective data analysis from health records, so CT imaging and various other health information from medical records. Now, another example of how body composition plays a role in treatment is a paper that we had put out last year. Here we looked at body composition as an independent determinant of a type of chemotherapy toxicity. 5-fluorouracil is actually a water-soluble based chemotherapy drug. What that means is that it is distributed and metabolized by water-soluble compartments in the body, which would be your lean tissue mass. Now, chemotherapy dosing traditionally has been calculated using body surface area. And body surface area comprises of weight and height. If we go back to the example that I used earlier, these two individuals have the same weight and height. They're receiving the same amount of chemotherapy dose. The patient on the left is most likely to exhibit a number of adverse toxic effects from the treatment, while the patient on the right is less likely to endure any of these adverse reactions. What was also particularly interesting is in a follow-up study, we looked at the relationship between body surface area and lean body mass and found that there was no relationship. So even though we use chemotherapy dosing with body surface area, there's no relationship to lean body mass. In fact, what we found is that if you take the amount of dose that was prescribed and relate it to lean body mass, there's a cut point above which patients would experience treatment toxicity. And this takes me to understanding and using this information to understand the time course changes that develop in patients. These are important questions simply because, one, this will help us reveal some of the mechanisms that are occurring and leading to these changes in body composition. And it'll help us identify the most optimal time to intervene and try and counter these detrimental changes in body composition. There is some older work and some more recent work that we've actually recently put out looking at changes that have occurred in the last year of life of colorectal cancer patients. And what we found is that there's an accelerated rate of muscle loss, such that in that last 3 months of life, patients are losing about 16% of their muscle in that last 3 months period prior to death. Now, fat mass is another story. We see all sorts of changes in fat mass. We're not quite sure what this is related to. In fact, we can see gains of fat mass of up to 20% and losses of fat masses up to 40% within a 3-month period, anywhere within this last year of life. We also see enlarged liver masses in some of these patients, or they develop large liver mass by the end of their final year. And this is particularly important in energy balance. Liver mass itself, or liver itself, has a fairly high energy expenditure. Actually, 1 kilogram of liver will expend 200 calories in a day. So small increases in liver mass can amount to large increases in expenditure, such that on average, the healthy individual might have a liver that's about 1.5 to 1.7 kilograms. Some of these patients actually have liver masses that rise up to about 15 kilograms. So you can see pretty quickly how energy expenditure is really disturbed in these particular patients. So understanding the time course in which these changes occur is really quite vital in order to understand when would be the optimal time to intervene. Intervening at a point when the patient is already losing 16% of their muscle mass may not be the most optimal time, but preventing that acceleration would be very beneficial and probably most effective. So I'm collaborating with Drs. David Koff and Jerry Moran at McMaster University to characterize a time course and change of muscle and various other lean tissues and fat depots in cancer patients. Particularly, we're looking at visceral and subcutaneous adipose tissue, liver, spleen, all of the abdominal organs. We're specifically looking at the abdomen and changes that are occurring in the abdomen. And we're creating volume rendering analyses to better understand the relationship between these different organs. This will enable us to identify the optimal time for nutritional, hormonal, as well as exercise interventions for different cancer patients. The evidence suggests that the extent of tumor burden may also drive muscle loss. Tumor, it does have a fairly high expenditure, and while it doesn't exist in large masses within the individual, it may still drive some of the increases in or acceleration in loss of muscle and fat. So our goal is to characterize changes in body composition during anti-neoplastic therapy and to relate these changes in tumor size with muscle, fat, and various other tissues. To do this, we'll be looking at retrospectively acquired CT images of patients who are diagnosed with colorectal, lung, and pancreatic cancers. The CTs will be analyzed for muscle, fat, liver, and spleen, and various other lean tissues, and identifying the changes that occur throughout that time period following their treatment. We can extract various amounts of information from the medical charts of these patients, including key dates such as diagnosis date, date of death if it's available, CT scan dates, as well as treatment dates. We can look at patient characteristics during this time that we're extracting data, and looking at cancer type and morphology may also provide us with really beneficial information for understanding what's occurring in this period of time. And of course, understanding the treatment plan that the patients are undergoing is also vital to look at time course changes. So this will enable us to identify various interrelationships between different tissues, and understanding the time course of changes in body composition will also enable us to identify the optimal time to intervene, rather than intervening at a point where there are some vicious cycles and metabolic changes that are occurring in a patient. Intervening at an earlier point in the trajectory may help us develop more effective strategies to counter some of these deleterious changes in body composition. The retrospective analysis of various health records will also provide a basis for future prospective and larger scale studies, and this is what we hope to accomplish with this particular study. Now, I also have a couple of studies that are ongoing and are combining retrospective as well as prospective work. For example, I am involved in a study with some of my colleagues at the University of Alberta, whereby we are collecting blood samples from patients on a weekly basis and then retrospectively analyzing their CT images and treatment data that's available to us. This has allowed us to identify a relationship between sarcopenia and different features of nutritional status, including essential fatty acid status. And we've just recently submitted an abstract to the Experimental Biology Conference in the spring, so that's exciting work to come. Closer to home, we're evaluating the development of sarcopenic obesity in breast cancer patients. We'll be looking at 20 newly diagnosed patients who are just about to start chemotherapy, and we'll be observing them over a period of 16 weeks. These patients will be assigned to one of two different groups, either the usual care group or an exercise training group, whereby they will undergo aerobic and resistance training programs. This work is going to be carried out at the WellFit Center, which is located at the Lyle-Hallman building. And actually the WellFit Center has been open for and serving cancer patients for the last 8 years, I believe, getting referrals from the Grand River Regional Cancer Center. So it's been a great program, and we hope to incorporate some more research in this particular center. The measurements that we'll be looking at in this particular study is dietary and activity records. Blood draws will include analysis for immune, lipid, amino acid profiles, as well as endocrine measures. We'll also be doing oral glucose tolerance tests to assess changes in insulin metabolism in these particular patients. And we'll also be assessing their physical activity and treatment toxicity through patient records. So we're really at the tip of the iceberg. We've learned that weight gain and weight loss occurs in cancer patients. We know that fat-free mass and fat mass changes dynamically throughout the disease trajectory. But we have underlying the surface of this iceberg is a whole other world, the how, when, and why. So we have a long way to go. And there are a large number of diseases from which we can learn from. There's a number of puzzle pieces that we can extract from these different diseases that will help us understand cancer, keeping in mind that cancer is a whole different puzzle in itself. Health databases can provide a wealth of information. I think I've I've provided some good examples here, and they can really help us design some future interventional studies. We have come a long way, though. Even though we have a ways to go, CT images have been a gold mine for us. One, they provide precise imaging. Access has been fantastic, as CT imaging is available in most cancer centers. These are carried out routinely, so we can actually track changes in patients. And CT images have really greatly advanced our work in body composition and cancer. So what's left is to relate these changes to nutrition, exercise, and metabolism. So we've had a lot of help along the way to do this, and have developed new colleagues along the way. So I just wanted to make quick mention. My collaborators in Alberta are listed here on the right. Dr. Vicky Barricos, Tony Ryman, and Linda McCarger have been essential in my postdoctoral work. My newer colleague, Vera Mazurek, is a fantastic collaborator, and she's the one that I'm working with in the essential fatty acid work. And Michael Sawyer has been essential in the pharmacokinetics area in relating body composition to chemotherapy. And of course, the work was in large part done by many of the students that were in that lab. Closer to home, Doctors Mala Ball, Rona Hanning, and Mala is at the Grand River Regional Cancer Center, and Dr. Rona Hanning is here on campus in the Faculty of Applied Health Sciences. Dr. David Koff and Gerald Moran are my collaborators at McMaster University. And of course, Ms. Carol Russell is the key coordinator of the WellFit Center. So she's been a fantastic source of information. And my master's student, Megan Bedbrook, who's been essential and will be carrying out the breast cancer study. Vivian Vance is a PhD student with Dr. Rona Hanning, and she will also be involved in the breast cancer study as well. Thank you for your attention.
Wow, an interesting presentation. And I mentioned to Marina I have to leave in about 5:02. Do you mind if I ask you a couple questions at the beginning, just to kick it off and get everybody to follow up on this? There are a lot of questions that come from this. The one that came clear to me, given all the interrelationships here and what is causal or caused, has anyone modeled this? Has anyone created a model of this, or where are you in regard to that?
That's a great question. And actually, one of the studies that I didn't quite present a lot of information because we've just submitted it for review, and that's looking at the changes in muscle, changes in fat, and changes in liver tissue. And we have someone who's actually simulating that data and giving us a better understanding for the changes in energy balance that occur in these patients in their last year of life. Currently, I've also talked to a few people from the math medicine department, and there is some interest, and we'll probably be embarking on a study fairly soon to try and understand and predict what these changes actually mean. And I think we're starting to develop a wealth of information that we can actually do some of this predictive analysis.
Yeah, we actually have a group that are involved in modeling of some aspects of the metabolism of warfarin, for example. And what we discovered was that there's a group within engineering, particularly chemical engineering, that's got a strong interest in this area. So that's another possible asset. The other one is going back to your data, and many questions about your data I won't be able to ask here today, but a quick one is image segmentation so that you can identify areas of muscle and fat, as you know, is problematic. I just read an article recently saying that the segmentation doesn't work in a number of situations. How sure are you? What do you see of your accuracy of the recognition of muscle versus fat mass, for example, particularly where you've got a lot of interstitial or intramuscular fat and the ability to actually recognize that on a reasonably accurate basis?
And that's a great question as well. And one thing we have based a lot of the data on is some of the healthy, the data that exists on healthy populations. So seeing the consistencies between the work that's been carried out in healthy populations and cancer populations really gives us some confidence that there are some clear depictions between skeletal muscle and fat. Now, you're right, it gets very gray when you start to look at intramuscular adipose tissue, in that the thresholds that we use of identifying the densities between the two tissues may not be as clear cut. What is evident is, even with muscle tissue that we measure in patients who, let's say, show an increase in intramuscular adipose tissue, we see a density decreasing in the muscle, suggesting that there's even further infiltration of fat within the muscle groups. So it's a very interesting area, and you're right, it gets a little gray. The one area that we are a little concerned with is when it comes to, and it's very obvious when you look at the scans, so we haven't included these patients in our analysis, but there are times when, let's say about 30 to 60 days prior to death, some of the patients show very different changes in their tissues, so it's very difficult to distinguish muscle from fat. But as I said, we haven't actually included those particular patients. It would be really interesting to identify the segmentation issues that we have in those particular patients, though.
There is one resource that might be, I've not thought of this except for today, that might be useful in this regard. The Visible Human Project at the National Library of Medicine. Yep. They've got the pathological slices, pathology slices, as well as CT and a whole variety of images. And it might be interesting to try the same segmentation algorithms on those images where you've got tissue evidence of the distribution of fat and muscle.
Absolutely.
Might be a way of just checking that as a question.
Just to follow up on that as well. With regards to the relationship of looking at the segmentation and healthy populations that I was referring to, there has actually been publications that have looked at comparisons between the MRI and CT images and cadaver analyses, so in healthy populations. So that's where, we have some confidence that what we're seeing is true.
Okay.
Yeah.
Questions? I'd like to open it up. And let me get you the microphone.
Have you taken bed rest into consideration? Because you probably know if you put healthy individuals to bed, there are significant biochemical changes
Absolutely.
can occur in the absence of any significant pathology.
Yeah, absolutely. At this point, we can't distinguish between what's pathology and what's bed rest and what's inactivity. In fact, one of the examples that I had shown where we saw an increase intramuscular adipose tissue within the muscle mass of the back, that's indicative of bed rest and inactivity. The patients that we've looked at were actually ambulatory. So they weren't bedridden, they weren't palliative care and in hospices, they were actually ambulatory. The extent of inactivity is a different story, and that's what we're actually looking into at this point in our future work.
Other questions? Can I get this to you? I'm sorry.
Thank you very much for your impressive talk. Actually, I'm doing my master in biology department. I'm working with animal model of human obesity. Okay. I would like to know that how do you know that this fat loss or muscle loss is not because of cell death, which is initiated by chemotherapy or radiotherapy drugs in cancer patients? And actually, my project showed that obesity does affect the apoptotic pathway in cancer patient, and patient with, not patient because I'm talking about the animal model. The animals which injected with carcinogen, and they showed the obesity features, they show more apoptosis and belong to more tumor development, both of them. Mm-hmm. And it was very interesting for us. This is the reason I'm asking that. Maybe it's because of cell deaths?
You're absolutely right. We don't know at this point. The only thing that we can allude to is some of the animal models, and even there, it's been very sketchy, and there's a lot of discrepancies. We will be embarking on a few prospective studies, actually, with one of my collaborators in the kinesiology department, Dr. Joe Quadrilatero, who looks at apoptotic signaling. So, if we can actually get our hands on some muscle from surgeries that have been carried out in cancer patients, that would be one way of approaching that particular question. So absolutely, that is one possibility. The other possibility that may be up for consideration is that muscles becoming resistant, and you start to see insulin resistance developing in patients who have who are undergoing chemotherapy, and that is part of the objective, actually, in our breast cancer study, is to identify whether insulin resistance starts to develop even acutely in the first phase of therapy.
I have to leave, but Shirley will take over. I just wanted to make one comment. Is 17% brain fat the threshold for calling someone a fathead, or is that... I was surprised that there's that much fat, but is that the general threshold? I'll leave you with one question. Is as you're aware, the inflammation has been largely associated with a lot of cardiovascular disease and atherosclerotic development and so on. What's the relationship between fat and inflammation? Is there one, or are they just coexistent? I mean, I just don't have the slightest idea of the answer to that. So.
Oh, I'm sure my students would love to tell you. We've talked about this a number of times.
Who wants to take a shot, just for fun?
We've talked about this a number of times in grad class as well. As what prevails? Is it what develops first? Is it insulin resistance? Is it inflammation? And where is this coming from? So there's a number of theories out there. Inflammation is one of those theories, but that's a whole other hour of discussion in terms of which leads to the atherosclerotic.
Is there a known relationship, though, between the buildup of fat and inflammation, or is that just...
There is, but we're not sure if that leads to the buildup of fat or if it actually coexists, and it's and if it's a cycle that is exacerbated with inflammation. So,
Are there any other questions from the audience? Oh, sure.
If you're talking about inflammation regarding vascular catastrophes, the current thinking is the C-reactive protein, which is a measure of inflammation, non-specific measure, has shown to be very, very positive in terms of development of problems that way. And cholesterol are now thinking is probably not that super important. Yeah. There's obviously another factor involved.
And there's a number of other inflammatory mediators that could be involved in the vascular damage. When we look at the cancer patients, and we have measured CRP actually in a group of our subset of our cancer patients, we see they're all over the place, even if they are obese, even if they do have other atherogenic indicators, such as their lipid profiles, their CRP are all over the place. And I think part of that has to do with when they develop these different lipid profiles and atherogenic indicators. But CRP is also very difficult to measure in cancer patients and actually distinguish whether or not that's going to predict cardiovascular incidences. So.
Any other questions? Well, I have one question, and that goes back to your WellFit or the WellFit program. Does it include not only exercise but nutrition advice? And
we rely on nutrition advice for the most part at the Grand River Regional Cancer Center. We have started to, we've actually gotten ethical approval, but haven't actually embarked on attaining nutritional information from patients. And to actually give advice, we would need to hire on a dietitian, a registered dietitian. That at this point isn't quite in the books. So.
Mm-hmm. I know at Grand River Hospital they do have the patient portal, and I think part of that includes the capability of the patient recording information along that line. I don't know if it includes nutrition or not, but that's my expectation that it would include that as well.
I believe it does. I'm not quite sure, but I think there are forms of attaining dietary information from patients who are currently at Grand River.
All right. Any other questions? Well, I thank you for a most interesting talk. So much information, as you say, that you've so many questions, but you have come a long way in this particular area. I think it's fascinating. I also love it because it's so interdisciplinary. I can see researchers all across this campus that would have a piece to the puzzle that you're trying to complete. So thank you for coming today. And this draws a close to our 2008 series of the research seminars. We'll be starting again in January. I hope you all come out again. It's been a great series, and it's so wonderful when we have people coming and listening and asking such great questions. So thank you for coming today, and we'll see you again.